Next, we go to Dr. Sheetal Brar, who was my fellow and senior consultant at Nethradhama, and now she has moved on to Punjab to start a practice there, and she will be demonstrating a case with the Hoya Impress.
Good evening, respected chairpersons and dear friends. Am I audible?
Yes, Sheetal, you're audible.
Great.
Very clear.
So, at the outset, I would like to thank Dr. Sri Ganesh, Team Nethradhama, and Hoya Surgicals for inviting me to this live surgery session and giving me this wonderful opportunity to demonstrate a case of Phaco flax with Hoya Impress enhanced monofocal lens implantation. So basically, this is a recent addition to the market of the enhanced monofocal lenses or the monofocal plus lenses that we have today. And what these lenses claim is a good functional intermediate vision after the surgery without any kind of deterioration in the visual quality. So, saline please. So I have been using this lens now since more than 6 months, and I have in my personal experience had a very encouraging experience, and the results are very good. Sir, light nodi please. So my patient today is a 65-year-old gentleman. You can see the cataract is quite soft, it's just a PSC. And because I'm in Nethradhama, I thought I can have the privilege to use femtosecond laser for the rexes and fragmentation, because I planned a 5.2 mm rexes, and definitely the laser is going to deliver it to me. And as we know that a well-centered and well-sized rexes is very important for proper centration and stability of the lens. So definitely this patient, I'm expecting it to be a good, this patient to get a good outcome after the surgery. So I'll start with the case. So the femto is already done, and sir, light nodi. So I'm injecting some Xylocard just to ensure that my pupil remains dilated throughout the surgery.
Dr. Sheetal, this is a posterior subcapsular cataract, as I can see from here.
Yes, sir.
What special precautions you have taken and you're going to take?
I will, during the surgery, be always cautious that my chamber does not collapse at any point, because sometimes these cases can also have a PPC component. So I'm making my entry wound 2.8, no? So it was a 2.8 keratome that I used, and that's the side port. Okay.
Your blades are very good. What brand blades are they, if you can?
That's, they are the money blades. No financial disclosure. So you can see that the rexis is free floating. The capsulotomy is free floating. It's complete. Visco please. Light nodi sir. Haan. And I'll just go under the flap. And push it out of the eye. Now I'll be very careful with the hydro part. One thing which is very important is that your chamber should not be overfilled with OVD. Hydro please. So I'll just do a very careful minimal hydro. It's also important to slightly decompress the nucleus and ensure that we have released the bubbles from behind the nucleus in these cases. Okay, you could see the posterior wave. going from one side to the other, and I will just gently rotate the nucleus, very gently. Okay. Visco, please. Can you give me visco? What I'll also try to demonstrate is the visco chop technique, which Dr. Ganesh described and we have also published. So if the cataract is grade 1 and sometimes up to 2 also, you can inject viscoat in the groove, the line please, sorry, visco, and try to separate the fragments just using the visco itself. But it looks like the nucleus has some density in the center, so I just go my normal way. Light nodi sir, seedha nodtare. So I'm using the Centurion active fluidic system for emulsification. IOP kammi ಮಾಡಿ 45. So I've just reduced the IOP. As you can see that the target IOP, as you can see that the chamber is quite deep. Innun kammi ಮಾಡಿ. So I'll just reduce it to 40. Patient is a myope patient. IOL power is 20. Okay, so the laser has already fragmented the nucleus into 4 fragments. So I just need to go in the grooves and separate them. Quadrant. So you can see all the 4 fragments are fully separated, and now it becomes easy for me to emulsify these one by one. Saline. It's very important to stay in the center when you are emulsifying the pieces. The rotation has to be very gentle. This last part I can just flip and chop. Cornea saline. Epinucleus. So to be on the safer side, I would just reduce the settings for the epinucleus. So PC looks fine. Visco, please. But I would just make sure that when I'm coming out of the chamber and withdrawing my Phaco probe, the chamber doesn't collapse. Aye, please. So the Hoya VVNex Impress enhanced monofocal lens has some unique features. One of the features which is very unique to this lens is its aspheric anterior optic, which makes it tolerant to some amount of decentration and tilt. So it can actually tolerate a decentration of up to 0.7 mm and a tilt of up to 10 degrees. So I'm just using bimanual IA system to remove these cortical fibers. Light note there is a Ramagiri. Good. Okay. So I would just clean these thin fibers which are sticking onto the posterior capsule using a hydropolishing method. You can also try to go from the side port. And flush this sticky material out. Okay. Visco, please. Yeah, load, please. Give me the lens for you. So we are ready for the implantation now. So this is the multi-cert injector from Hoya, and this injector is same across all the lenses of Hoya, the geometric, trifocal lenses, Hoya Impress lens, and their monofocal and toric lenses as well. Cornea saline, please. So it can be used both as a pusher as well as a screw type injector. However you are comfortable, you can use it as per your preference. It also has something known as insert shield. So if you just bring this forward, this part, this flap, so what it does is that it helps in the wound assisted delivery if you prefer that, or otherwise if you prefer in the bag implantation like I do, you don't need to adjust the insert shield. Cornea saline. So you can see that the nozzle is thinner. It's 1.7 mm, the tip size, so it goes easily through a 2.2 incision also. And the delivery of the lens is quite smooth and always very predictable. I think you can also appreciate the textured haptics. Okay, you can see that the haptics have been modified. They are slightly roughened, Tyler. So they are slightly roughened basically to improve the stability for toric versions and otherwise also. And this also prevents the sticking of the haptics with the optics. So that's the advantage of the textured haptics. So I would like to orient the lens horizontally. So what is the technology behind this lens is essentially it's a proprietary technology. The principle is that in the center, please. Yeah. So in the central 2 mm zone, light nodi sir, light nodi, 2 mm zone, there are microcurvatural changes. So there's a refractive element that has microcurvatural changes and that causes changes in the power. And what happens is that there are small peaks and valleys through which the incident light basically it increases the depth of focus and the light converges in front of the retina and you get a very good depth of focus with these lenses. So we have studied the defocus curve also and I've seen that it gives us around 1 to 1.25 diopters of depth of focus and that has actually reduced the need for reduced the ad for the reading as well for these patients. So they are very comfortable with the intermediate vision. They're able to do most of the tasks without the need of glasses. And if you look at the topography of the lens, it's quite smooth. You're hardly able to appreciate the central 2 mm refractive zone. So it looks like a standard monofocal lens only. And this is the reason why patients are quite comfortable with the vision. Light nodi sir, seedha nodi please. They don't complain of any dysphotopsia and quality of vision is also great with these lenses. So I'll just go behind also and flush.
Sheetal, what's the effective ad of this lens and what do you target as your refraction?
So there's no ad on this lens. It's just the central 2 mm zone, as I said, has a small refractive zone that has been modified and that has micro curvatural changes. They are very tiny peaks and valleys. Of course, these are not visible, Connie Celine, please. Not visible on the lens. So that increases the depth of focus. So there is no ad as such.
Yes, but there must be some functionality in terms of ad. And you know, surgeons need a guideline as to how much power there is in the lens.
Basically, it's a proprietary technology, but it increases the depth of focus by about 1 to 1.5. Yeah.
And do you target a
Lightly.
minus outcome or do you target plano?
Could you please repeat the question?
And what's your refractive target?
Refractive target is always emetropia. I have never targeted a myopic refraction for these patients, but I think how surgeons have been doing with a little mini monovision concept, that also should work with these lenses. So you can see that the lens is quite well centered and stable in the bag.
Yes, very nicely done. So the last question.
Thank you so
You
much.
know, like the Vivity and the Pure C lenses, they are actually quite expensive. They're priced like trifocal lenses. So is this priced like a monofocal or priced like a trifocal or expensive
Slightly more expensive than the monofocal,
Okay, so that's
but less than the EDOFs.
Yeah.
Yeah. Thank you so much.
Wonderful surgery, Dr. Sheetal.
Thank you, sir.
Can you tell us about the defocus curve of this lens vis-a-vis VVT or monofocals? You said you have done defocus curves.
Yes, we have done defocus curve for these lenses, and what we have seen is that in the intermediate zone, basically at 1.5 diopters, the lens gives good visual acuity of around 0.1 logmar or better. So we have compared it with some other lenses also, enhanced monofocal lenses like the Technis iHands, and in the intermediate zone at 1.5, it provides better intermediate vision by about 0.1 logmar.
What do you think are the clinical indications for this? Those people who drive a lot at night time, or those people who work on system? When a person cannot read, say bilaterally if you implant these lenses, is a person able to read text from the mobile?
So it can be, there's no specific indication. It can be used as a replacement of a monofocal lens also, because they're just giving an added advantage of functional intermediate vision. So that, and the quality of a distance vision does not get affected. So there are no dysphotopsias or halos. So it can be safely implanted in people who drive in the night and also who work on the laptops and systems. Patients are quite comfortable and happy.
Does the valleys and peaks that you mentioned in the central 2 millimeters,
Yes.
would it affect the night driving?
No. The transition is very, very smooth in the 2 mm zone, and beyond the 2 mm zone, it's the standard aspheric optic. So it's good for the distance vision.
Thank you very much, Dr. Sheetal. It was
Thank you,
wonderful.
sir.